Scenario 1 Digestive System Gastroenterology. Gastric ulcer with massive upper gastrointestinal bleeding. A 58-year-old female was rushed to the emergency department following 3 bouts of hematemesis and a single bout of melena. On examination, she was tachycardic and hypotensive at 121 beats per minute and 90 over 50 millimeters of mercury, respectively. She manifests pallor with no icterus. She is eupneic and normothermic, but reports intermittent periumbilical tenderness. Medication history reveals occasional intake of a nonsteroidal anti-inflammatory drug, naproxen, 250 milligrams for arthritis management. On admission, her complete blood count revealed a hemoglobin level of 5.1 grams per deciliter, hematocrit of 32%, prolonged prothrombin time, and positive guaiac test. All other laboratory studies were within normal limits. Based on these clinical presentations, intravenous fluids were administered and 3 bags of packed red blood cells were transfused. A gastroenterologist was consulted and a gastrointestinal endoscopy was performed, which revealed a 1 by 1 centimeter hemorrhagic gastric ulcer. The bleeding ulcer was cauterized and biopsies were taken for Helicobacter pylori, the results of which are negative. Proton pump inhibitors were started and she was discharged after 2 days in stable condition. Scenario 2 Diabetes Subsequent Diagnoses. Uncontrolled non-insulin dependent diabetes mellitus. A 58-year-old female with non-insulin dependent diabetes mellitus was seen in her primary care provider's office with reports of diminished sensation in both feet and occasional blurred vision. The client admits to problems adhering to her prescribed dietary and medication regimen. She doesn't exercise regularly, takes her medications only when she is reminded, and doesn't watch her diet. She denies dyspnea, polyphagia, polydipsia, polyuria, and diaphoresis. The client had a history of non-insulin dependent diabetes mellitus for 15 years and dyslipidemia and hypertension for 8 years. She has had photocoagulation for retinopathy in the past year. She is on metformin and glipizide for control of hyperglycemia, hydrochlorothiazide, and ramipril as antihypertensives, and atorvastatin for hyperlipidemia. Upon examination, her blood pressure is 185 over 98 millimeters of mercury. Fasting blood glucose is 265 milligrams per deciliter. Hemoglobin A1C, serum blood urea nitrogen, and creatinine at 53 milligrams per deciliter and 4.4 milligrams per deciliter, respectively. Urinalysis and 24-hour urine collection uncovered trace protein and urinary albumin excretion rate of 255 milligrams per day, leading to a diagnosis of microalbuminuria. Nerve conduction studies and electromyography confirmed diabetic neuropathy. Decreased visual acuity and new extensive reticular vascular growth were revealed through an ophthalmologic exam. Based on the client's typical presentations, the final medical impression and diagnosis is uncontrolled insulin-dependent diabetes mellitus, complicated by hypertension, dyslipidemia, neuropathy, retinopathy, and microalbuminuria.